that this public hearing is being recorded. Because the hearing is public, participants and viewers have no reasonable expectation of privacy. By continuing to be in the meeting, you are consenting to be recorded. Additionally, prior to recognizing members for questions or comments that they may have for witnesses, I will note for the record at this time that we will use the chat feature available in Microsoft Teams to allow members to signify that they wish to be recognized. In order to comply with the Sunshine Act, that chat feature must only be used for this purpose. Before we call the first panel, I want to ask Councilmember Bass if you'd like to make any opening comments.
Well, thank you very much to my colleague and co-chair, and also I want to thank everyone who took the time out to be a part of today's very important hearing. We know a lot now since we've learned a lot now since COVID was really introduced to the Philadelphia region in early March. One of the things that we learned is about disparities. And for those of us who've been working on disparities, whether they be racial or health disparities or a combination of both for quite some time now, this was even a new turn on all of us as well. Because what we learned is that the problem of the disparities and the differences in treatment goes even further and even deeper than we even expected. And so I'm looking forward to today's hearing and trying to find ways that we can address these issues. They've been going on, and my office has been working on these issues for a long time now. And it's good to have more people at the table, more conversation, really just trying to find ways to address this. We need more than just a couple people working on this in silos. We all need to be working on this issue together. So again, I just really want to say thank you to my colleagues. Thank you to Chairman Green, and for all of those who are willing to pitch in and try to make this whole situation better, because I believe it can be better. I believe that we have the resources. I believe the city of Philadelphia has the money that it needs to be able to address disparities throughout neighborhoods. I believe we have a thriving health and medical community, which can add to the issue of disparities in a positive way and address these issues so that we don't have what we have right now, which is a tale of two cities. So I believe collectively we can make change. We can get some things done, and I'm looking forward to that today. So thank you, Mr. Chairman.
Thank you, Councilmember Bass. And as we begin this hearing, we know that the city of Philadelphia did not create racism. City of Philadelphia did not create COVID-19. But we do know that 44% of the citizens of this city are of African descent. And so we as a city have a responsibility to do all that we can to address this issue. Too many of our citizens have been disproportionately impacted by this pandemic, not only from a public health perspective, but also from an economic perspective. And that expands not just in the African American community, but also our Latin community, as well as the disability community. All of these communities were having major challenges in reference to public health before COVID-19. What COVID-19 has done is only illuminated the disparities that many people in our city are dealing with every day. And so we have to do what's our responsibility as members of the executive branch, of the legislative branch, to do make changes. This issue did not happen overnight, but we can't shirk our responsibility. We as elected officials, as members of the executive branch, the general public, those who are leaders in our community need to do what needs to be done to address this issue. We just can't put our heads in the sand and say this is a challenging issue that came before us and will last after us. But we have to do what we need to do if we're going to step up and call ourselves leaders. And so this is part of a conversation that started long before I came into council. But COVID-19 has really demonstrated these major disparities that we have in our city and in these communities. And from my perspective, the goal of this conversation today is to highlight some of the challenges, some of the things that we have done, but also allow us to move forward and continue to move forward and struggle to address this issue in our city. I look forward to this conversation and additional conversations as we try to address this issue that impacts our entire city, not just the communities we're discussing today. So with that, Mr. Anuzzi, yes, I believe that was Councilmember Thomas.
Yes, sir. I just want you to know I'm present. Thank you, Mr. Chairman.
Okay. Thank you, Councilmember Thomas, for stating that. We will now move into our first panel.
Mr. Chair?
Yes.
Good morning. This is Councilmember Catherine Gilmore Richardson. May I be recognized?
Absolutely. Thank you, Councilmember Gilmore Richardson.
Okay, good morning. Thank you to my colleagues and to both committee chairs, Council Members Green and Bass, for hosting this very important hearing today. As we all are aware, and as you have already demonstrated in your remarks, COVID-19 has disproportionately impacted communities of color across the country and here in Philadelphia. Research has shown that racism, not race, is what is causing the vastly disproportionate impact that COVID-19 is having on people of color. Systematic racism and structural oppression forces people of color into substandard housing that is more crowded, requires us to rely more heavily on public transportation, and to be more likely to work on jobs in the front line, our essential workers, as well as have underlying health conditions tied to food deserts, toxic air pollution, and lack of access to health care. Research by Dr. Barber at Drexel University found in Philadelphia's most segregated zip codes, the rate of COVID-19 infection was 23% higher than the citywide average and 2 times higher than that of the least segregated zip codes. However, when the city began testing, where was testing most easily available? Not in these predominantly Black neighborhoods, as researched by Dr. Bilal, another epidemiologist at Drexel. The data is clear. Black Philadelphians are more likely to get COVID, more likely to be hospitalized, and more likely to die, and we have less access to testing. This is unacceptable, and another example of how generations of racism continues to kill Black Americans today. So I just wanted to say thank you so much to my colleagues, both chair members Green and Bass, for hosting this hearing today, and for the experts who are joining us. We as the elected leaders of our city are responsible for ensuring that access to testing and treatment are available to everyone. So I look forward to continuing this work with all of you, and thank you so much for your work. Thank you.
Thank you, Councilmember Gilmore Richardson. We are about to start the panel. Mr. Stanley, if you can make sure that Reverend Marshall Mitchell gets the link to be let in. For some reason, that has not been sent by tech staff. Mr. Anuzzi, if you can start with the first panel.
Senator Art Haywood, Representative Jake Wheatley, Dr. Ayla Stanford, and Reverend Marshall Mitchell.
And if you could proceed in that order for your testimony, and then we will then open up for questions from members of council.
Thank you very much. So this is Art Haywood, State Senator. I hope I was first because I got a little bit distracted. If I'm not, whoever was first, please allow me to continue. First of all, I want to thank City Council, Councilman Green and Councilwoman Bass for their leadership, all the council people who are connected with this hearing. State Senate had a why Black people are dying public hearing in June on the disproportionate impact of COVID on African Americans. And so this is one of a number of hearings in which I've participated. They all come down to a few factors, which the Councilwoman already identified several of them. I think the question now is, what can we do and what should we do now? Here are a few answers. Number one, we need to support testing in the African American, the Black and brown communities so that those communities can be tested, the tracing can then be followed, and the quarantine can then be followed. What I'm saying now is nothing new. It's been said many times. And so I think that at the city level, one of the key actions that need to be taken is get money to the trusted physicians who can do the testing, get money to the trusted folks who can do the tracing, and organize a quarantine system to that end. Dr. Ayla Sanford's organization, along with Pastor Mitchell's, is the leading organization in the United States of America for the testing. They can do the tracing. So I think getting the money to the trusted people is the number one thing that we can do as elected officials, since our job is largely resource allocation, dealing with the question of who gets the money. Second thing I'd like to say briefly is that systemic racism is not invisible. It is not invisible. There are a set of rules that protect and permit systemic racism. And I want to share a couple that may not be seen as directly related to our challenge today, but are. Black people were paid nothing during enslavement, paid little during segregation, and we're in a bunch of jobs that are historically called black jobs. These black jobs are, as we all know, janitorial jobs, cleaning people's homes jobs, the traditional jobs. Today, these traditionally black jobs are jobs that pay 7 1/4. They are the low-paying jobs in our nation. We all probably on this committee know we got to get the minimum wage up. We got to get pay up. And if we get pay up, we can create more opportunity for our folks so that they have more choices on their living conditions, the density questions. So systemic racism is related to rules that we in government have created. I'll give you one more rule of systemic racism, in addition to low pay. Deny black people quality education. We know that during enslavement, it was illegal to educate black people. In segregation, we had separate and unequal. And today, the funding of the schools that educate black children is severely underfunded. We can generate more opportunity for our young people by fairly funding our schools and getting some decent race curriculum in the schools. My topic today, I know, has gone somewhat beyond the conversation of healthcare, but it does go to systemic racism, which undergirds our society and our experience in the United States of America. I would like to say that Calissa Freeman, who's the Executive Director of the Health and Human Services Committee, of which I am the chair, will be on this committee hearing throughout. I have to leave at around 11. Those are the key comments that I wanted to make, and I'd be glad to take any questions about anything that I have said or not said. Thank you.
Thank you. Representative Wheatley.
Thank you. Good morning, Chairpersons Green and Chairperson Bass, and all the other distinguished honored guests, council persons of the joint committees of people with disabilities and special needs and public health and human services. Again, I'm State Representative Jake Wheatley. I'm the senior member of the Finance Committee in the State House. I've served in the State House for about 17 years, and I'm also an honorably discharged disabled veteran of the First Persian Gulf War. I have prepared testimony that I'm not going to read through. I'm just going to submit to you all. But I wanted to kind of go off of what Senator Haywood was saying. And first, I want to thank our current governor, Governor Wolf, in one respect, because he, I believe, has tried to really get at some of the systems that we are discussing today by recognizing the fact that we have to do drastic changes around our criminal justice. We have to do a more focused, intentional, targeted effort to try to help put economics and resources into our businesses, especially our historically disadvantaged businesses. But the challenge to his efforts are most of them are administrative. He's tried to do it executively. What I am attempting to do with some of my colleagues in the House is to recognize racism as what it is, as an institutional and systemic problem in crisis that has major implications not only to Black and brown citizens of the Commonwealth, but to our whole society as we are trying to push forward to maximize all of the quality of life and all of the resources that we have that we're investing. And in our attempt, I have a bill to actually declare racism as the public health crisis, similar to what you're seeing in other states and throughout the Commonwealth and throughout the country. I think there's no debating that structural and systemic racism has existed, is existing, and through governmental actions has been able to sustain the disparities between groups of citizens, primarily based around their skin tone and skin color. And what we are hoping to do with our bill is, one, identify it, recognize it, state it as a serious issue that leaders at the State House and in the State Senate and in the governor's mansion want to address and do something about. And then we actually want to put resources and time and attention to address it. We know that there are root systemic problems and challenges that whenever we try to do one-offs, all we're doing is rearranging the deck, but we're not really changing it at its core. What we're trying to do with this task force and this bill is to make it a part of our process, just like in our appropriation process, when we're considering bills and its impact to our financial outcome, we should consider any changes in law or any initiatives that we do at the state level and what it might do to our equitable, or what it might do to our systems that are inequitable. And so we want this task force to really play that critical role, to be that lens, to be that process by which all these decisions will be vetted and then recommend to the General Assembly and to the governor courses of action that lives beyond just one individual and one moment in time. And long story short, I think this moment in time, this pandemic has shown us that we certainly do have two systems, two groups of people living in one Commonwealth and one country, and that is not always equal, and that we can't just continue to allow those systems to live on if we're ever going to maximize our best potential. And I say it has economic realities, it has systemic realities, and it has real live implications that goes beyond just those people who are impacted by the structures of racism. And so I'm glad to be a part of this conversation. I look forward to working with all of you. I know one of the council persons earlier talked about the Philadelphia numbers, but unfortunately those numbers play out all across the Commonwealth, in Pittsburgh, and then all across the country. We see in communities of color specifically, and primarily African Americans and Latinos, who, because of the pandemic, we see those things which we already knew, from a health outcome perspective, from an economic perspective, from a violence perspective. And so we really want to use this opportunity to really lift this conversation up to where it's supposed to be. And every conversation we have in Harrisburg should be including the equity lens. So I appreciate the time and moment today, and will make myself available for any questions. Thank you.
Thank you. Thank you. Dr. Stanford, thank you for being here and for the work that you're doing, and we hope to be able to bring in Reverend Mitchell shortly.
Okay. Good morning, everyone. Thank you for the invitation to address the city of Philadelphia and city council members. My name is Dr. Ayla Stanford. I'm a pediatric surgeon and founder of the Black Doctors COVID-19 Consortium. I formed the organization because Black people in Philadelphia were being diagnosed and dying at a rate higher than any other group, and there was not a concerted effort to decrease that death and disease on April 16th when we started. And the people who joined in volunteering without any pay were because the lives of Black people were important and they wanted to do something about it. We only have 5 things in our arsenal to protect us against coronavirus. We know that there is no cure, there is no vaccine, and treatment and supportive management is all we have. So those 5 things are education, testing that includes contact tracing, social distancing, mask wearing, and hand hygiene, period. We know that testing is critical to decrease the spread and for us to identify people. So everything I talk about is about that in my 3 minutes. Why is it so prevalent in the Black community? I want today for everyone, for no other reason, to stop saying it's the social determinants of health, that it's because Black people are not healthy, because they're obese, because they smoke, because they don't listen, because their diabetes is not controlled, because their hypertension is not controlled. That may be a point, but it is not the only reason. And I know this because I am seeing people every day that tell me that's not the reason. It's because when an elderly funeral home director in West Philadelphia tries to get tested and you turn him away because he doesn't have a prescription, that has nothing to do with his hypertension. That has everything to do with your implicit bias. When a Black healthcare worker can't get tested at work because their white superior says you're not sick enough and you don't meet criteria, that's someone exerting their own bias against someone else. When a person can't get a prescription when they show up somewhere because their doc is not on staff, that's a problem. When you need a state-issued ID in order for someone to test you, that's a problem. And I don't know if you can see this, but this was just yesterday. And it says, must have prescription note and must have ID. What does the ID have to do with you testing someone for coronavirus who thinks they may be exposed? The hours are 9 to 5. There are no hours on weekends. How are people supposed to get tested? We don't want to go back to the times where Black people were told, stay home, only come to the hospital when you're really sick, write down your symptoms, waiting for a telehealth call. So many people died in their homes writing down their symptoms. How do I know? Because the next day, the family members came to our testing site saying we were waiting and they died at home. We cannot go back to that. This is not my opinion. In June of 2020, MIT and the Brookings Institute out of Washington, D.C. put out data showing that it's not Black people are unhealthy, that a large portion is contributed to population density, your occupation, and lack of access to care. The bottom line, and these are the real-time examples in my last 45 seconds. The CARES Act gave $44 billion to Pennsylvania, of which $579 million went to area hospitals, $100 million to Jeff, $70 million to Penn, Temple, and so on and so forth. And yes, that was to help them with the money they were losing not doing procedures. But where was the outreach to the most vulnerable population? And I know the elderly is a vulnerable population, representing about 125,000 people in Pennsylvania. But 44%, or 705,000 people, are African American. So even if you round it up and you included the healthcare workers that work in the nursing homes and the personal assisted living communities, 200,000 to 700,000. Where is the push for those individuals? The Pennsylvania Department of Health allocated $125 million to Temple, to Jefferson, to Penn, to help decrease the spread in the nursing home and those agencies. Yes, that should happen. But where is the $125 million to Black communities in 19120, 19140, 4339, and 19131. Every one of those zip codes has a hospital that, remember, received a portion of $4 billion to be spent by December 31st, 2020 to mitigate the spread. I haven't seen it. I know that there are more pop-up units, but if they're only till 5 o'clock, what about the folks that are working and we already know we're face front? No hours on weekends. You still need a script. This is what I would suggest. I would suggest that Penn and Jefferson and Temple and Einstein and PCOM and all these hospitals that have in-house testing, meaning they get their results back as soon as 4 hours, sometimes 2 days. Meanwhile, the folks I'm testing are waiting 10 to 14 days to get their results back. How are we supposed to contact trace and let them tell the people they've been in contact with so you can stop the spread? It's taking 2 weeks, but yet the hospitals that got millions of dollars have a test that you can get the results back in hours. So I would propose for an action item that 1 day a week, all those hospitals that got millions of dollars from the CARES Act and from the Pennsylvania Department of Health decide that for 24 hours or from 9 a.m. to midnight, you're going to open your doors. You're going to provide barrier-free testing, that they don't need a referral, that they don't need a state-issued ID, just that Monday is Einstein, Tuesday is Temple, Wednesday is Jefferson, Thursday is Penn, Friday is CHOP, Saturday is Lincolnall, and Sunday is PCOM. And you do that around the city. There's no reason why you can't. You have the in-house test. You're getting reimbursed from the CARES Act for every uninsured individual. There's no reason why you can't test them. So you use the manpower and the money that was given to mitigate the spread in our hard-hit communities by December 31st, 2020, and make it happen. We have the resources and the expertise in our city to do that. I am here. I will help. Put me out of business. I'm a pediatric surgeon. You are institutions that have been present for hundreds of years with infrastructure and have not lost money because money keeps coming in from the government. Don't just stay in the hospital. Leave your edifice. Go out to the communities that need you most. Partner with us. We will help you with the trust that lacks in some of your institutions.
Testimony. Reverend Mitchell, I believe you are on.
Thank you very much, Mr. Chair, and to Councilwoman Bass. Nice to see you and good to be heard. Unfortunately, I'm just via audio, so I don't have the advantage of two-dimensionality. We are in the middle of a three-dimensional crisis and a war, and people like Dr. Stanford have stepped up to fight this war, and they've been sent off to war in many instances without any ammunition, but they have still done a heck of a job of fighting this battle. I'm the pastor of Salem Baptist Church, which is in the fair county of Montgomery, in the town of Abington. I do not pastor in Philadelphia. Dr. Stanford and I are native son and native daughter of the city, and we've tried to ride as best we can to help the city. Your pastor, Pastor Derek Brennan, and people like Pastor James Buck at Grace Baptist Church, Pastor Alan Waller, and countless other pastors, imams, leaders of our community stepped up at a time when government unfortunately waited, was caught flat-footed, and did not ride into battle with Dr. Stanford. So as a result, instead of the city with its scale or the state and federal government with their scale stepping into this battle, we were forced to step into the battle with churches that were closed, that did not have the advantage of tithes and offerings at a time, and so everybody has been suffering throughout. But nonetheless, there have been organizations which have stood right behind Dr. Stanford, sometimes with old church ladies with crumpled $5 bills, sometimes with churches that came up with water, sometimes with churches that had nothing more than a parking lot, but they gave what they had, and they gave out of that sense of spirit. And what I'm hearing Dr. Stanford say is we have multiple billion-dollar healthcare institutions in the city of Philadelphia who gave little or nothing other than lip service. And that is awful because those institutions, these world-class institutions, benefit from being in Philadelphia. They have benefited from the CARES Act. They have benefited from the sense of crisis that befell our nation's healthcare institutions. And so people rallied to their side. In a much, much slower tectonic shift to help, Dr. Stanford continued to test out on parking lots and do what she could do to keep the city of Philadelphia's most vulnerable people safe. One of the things that I have observed, my primary job working with Dr. Stanford is just making sure the parking lots work. But I can tell you this. I have watched her do miracles with little or no support coming from the city govgovernment, and the state to some extent. Now, everybody is getting into the game, and I know she is grateful for that, and the city of Philadelphia and its people are grateful for it. But we should never have another situation where Dr. Stanford and others have to ride into this kind of battle with little or no support and supplies. That simply will not work. We need to be in a war footing and have a war posture. And unless we do, we're going to find ourselves again in the same situation. For me, it was very curious because we knew that African Americans were contracting this and dying at a rate that was much higher than their percentage of the population. And there was no sense of emergency, because when there is a sense of emergency, people pull fire alarms, and when you pull a fire alarm, you expect that eventually the firefighters will come, the fire trucks will come, the water will come and save you. And unfortunately, that only works if people come in about 15 minutes. It will never work if after 3 months or 4 months, heroes like Dr. Stanford and her nurses and other physicians are still waiting for the city, the state, and the federal government to show up. We're waiting for Superman, but we're convinced Superman ain't coming. So I want, on behalf of the clergy people in the city of Philadelphia, people like Pastor James Buck, who was at Grace Baptist Church, who tested positive, and thank God Dr. Stanford was there to test him. Pastor Alan Waller of Enon Tabernacle Baptist Church, he tested positive. Dr. Stanford rode to his rescue. Pastor Doug Banks of Mount Zion Baptist Church in Germantown tested positive, and thank God for the black doctors. But that burden should not exist on the shoulders of one heroic lady leading other people into battle. That has got to be a city, a state, and a federal approach to fighting this. So I want to encourage you all to get all of the black churches in Philadelphia out of the COVID-19 business and have Philadelphia city government step up, get into it, and recognize this is a historic fight that they need to lead.
Thank you, Reverend Mitchell, for your leadership. I want to thank Dr. Stanford, Representative Wheatley, Senator Haywood for your comments. The Vice Chair of the Montgomery County Commissioners, Ken Lawrence, hopefully will be able to come on to the hearing a little bit later. I reached out to him because he was a beneficiary of the work of Dr. Stanford and the Black Doctors COVID-19 Consortium, because he tested positive for COVID-19. And so this has been an issue, not just here in the city of Philadelphia, but it's an issue throughout the entire region and throughout the entire Commonwealth. And so I want to open it up to questions from any of my colleagues in council as we are looking for some of the questions that they may have. My thought is, and Dr. Stanford, you provided some information about an idea that you posited, that having our local hospitals that are doing in-house testing expand their work. Just this morning, I received an email from Einstein that they are now going to be doing testing on Mondays and Wednesdays from 7 a.m. to 8 p.m. and on Saturdays from 9 to 5 p.m. for no fee. But you made a point that's important, that you do not have to provide a driver's license or photo ID or not have a referral. What type of impact does that have on people in the African American community and getting tested when they're told up front that they have to have identification or have a referral from a physician?
I mean, people retreat and recoil when they hear that. It's just more barriers. It's like asking them to sign something that's 20 pages long with vocabulary that they may not understand, right? And so the reality is you need a person's name, you need a date of birth, and you need a way to contact them. That's it. When we test people on the street at Broad and Olney or 52nd and Market, those were the only 3 pieces of information we needed, okay? Regarding the health insurance and the CARES Act, you need to know if someone has insurance or doesn't have insurance, because they will pay if you don't have health insurance. But if you do, and then it pops up later that you didn't disclose that, then you have to pay the government back, and it can be messy. And I'm sure that's what they're thinking. We don't want to have to deal with the messiness, but it's going to be some work on the part of the hospital. If they test 500 people a day, then they're going to be responsible for getting the results back to 500 people. That's what we have to do. And we're a group of, 30 people, and we've tested now 8,000 people since April, right? And so it's more than 30 in a hospital, but it means that, no, it's not your patient. It's going to be more work for you to get their history, but you gotta call them back. This is a time where everybody has to put in the extra effort.
Thank you, Dr. Stanford. I see Councilman Bass has a question, so we'll do Councilman Bass, Councilmember Thomas, I think you have a question, and Councilmember Gim. And then we're going to close this panel. We want to go to Dr. Farley. We may come back to this panel with additional questions. Some of you may have to go, but we want to make sure we get a chance to hear from Dr. Farley as well. So let's go with Councilmember Bass, Councilmember Thomas, Gim, and Councilman Gauthier.
Good morning. Good morning, Dr. Stanford. How are you today?
I'm good.
Good. And Pastor Mitchell, you as well. Greetings to you. I just wanted to follow up on, good to hear your voice as always. I just wanted to follow up on just touching on what my colleague spoke about, which was the requirement that identification be presented, and that this is a recurring concept, if you will, of disenfranchisement, when it becomes you have to have, at one point it was you have to have identification to vote. That was the conversation that was being had, and the arguments were being made that you can no longer vote without identification. And thank goodness that was beaten back. But now when you have a life or death situation and you're requiring me to produce identification before I go, it just goes back to the feeling that a lot of people have in the African American community, and I know Dr. Stanford, you are very familiar with this, that we don't have confidence in our medical community. We don't have confidence that you are going to really treat me. We don't have confidence that you are going to care for me when I am hospitalized. I have heard stories from some folks in reference to the way that they felt that their loved one was treated. A young lady in particular who does a lot of work with my office, she lost her grandmother, and she told me about how the nurse said to the grandmother, well, you're going to die. You're going to die. And said to, the granddaughter who has done some work with my office, said to the granddaughter and a cousin, well, she's going to die. And so it's almost, she was a senior, but she really didn't have any underlying health issues. But she was up in age, but otherwise she was very mobile, very much able to care for herself. But the treatment she received and just the dismissiveness in which she was treated by the healthcare industry here in Philadelphia is, it's beyond just hurtful and embarrassing and just unprofessional. In some ways it should be looked at really as criminal. If you don't want to do your job, which is saving lives, then that to me should be something that should be looked at as a criminal offense, because you have people's lives in your hands, and it's to be taken very, very seriously. So, I just really wanted to put that out there because we need to remember that the African American community in particular, and I think, really for all communities of color, but particularly in the African American community, we've had these experiments, the Tuskegee experiment and other things that have been done in which African American bodies have been, sort of researched and, looked at in a way that is not an attempt to be helpful, but an attempt to sort of label us as something other, as something exotic, as something, different, if you will, in a way that's not really productive to helping our people with some of the issues that have been historic as a result of, going back to slavery. I have high blood pressure today because I know that my family before me, my ancestors, those who came before me, were eating so much pork and such a low fiber diet and such a poor diet altogether. And so it is something that just runs in my family. It doesn't matter how thin you are, how heavy you are, what you do. This is something that is going to be carried for generations because it's been in our family for just so very long. And it's the same thing with diabetes and other things. We can try to mitigate all we want, but there are some things that just have been systemic for a very long time and have not been addressed and continue not to be addressed by the medical community. So I just really wanted to put all of that out there. I thank you for the work that you're doing. You really are a hero. You really, in my opinion, you really have come forward and saved the day at a time when the city of Philadelphia really just stood by. Our city didn't do what it was supposed to do. We're supposed to be ready for this, and we weren't, and we got caught flat-footed. And without you, I dare to imagine where we would be right at this very moment. So I thank you. God bless you for all that you have done, and stay strong. Stay strong. Thank you so much.
Thank you.
Thank you. I believe Councilmember Thomas is next.
Thank you, Mr. Chairman. Thank you, Madam Chairwoman, as well, too. I appreciate you both convening this important conversation. Thank you to my state partners as well. I appreciate the work you're doing in Harrisburg. It's very important. We need your support and your partnership. And, of course, thank you to Reverend Marshall and Dr. Stanfield. I agree with Councilmember Bass. You guys are heroes, and I'll take it a step further and say that your story needs to be told. Our young people across the city of Philadelphia are experiencing more negative narratives right now than positives. And I think it would be awesome if we can put what you're doing on a platform, not just recognizing what you're doing in political spaces, but every Black Philadelphian should know exactly how you stepped up to the plate and what you've done to essentially help save hundreds, if not thousands of lives across the city. So thank you. I appreciate you. I just want to get your opinion on two issues. The first is testing. So I'm just curious to know from the testing that you've done, how many reoccurring positive cases have you had? My second question is around youth in sports. Reverend Mitchell and I have talked about this, and we've bounced ideas off of each other as far as council, the school district, and other parties. And I'm curious to hear your opinion as it relates to extracurricular activities this fall. There's a strong chance that we'll be going mostly virtual as it relates to the type of education that we'll have, but there is also a strong push to allow extracurricular activities even if we go virtual. And I can imagine, I'm sure you can imagine the type of pressure that coaches and athletic directors are under now that people see professional sports taking place. So I would love to hear your response to those two things, and I want to thank again the chairs for convening this important conversation, and I appreciate everybody involved. This is great information. Thank you.
Wonderful, and thank you for your comments. So first, we haven't seen anyone come back and become positive again. We have seen people that have sort of a prolonged course, meaning they're positive 8 weeks later, but they are still having symptoms. And for the folks that are not having symptoms but test positive, we now know that that's probably some of the antigen and so forth, which is like residual portions of the virus that are still in their nose or in their mouth. And that's why they are testing positive even weeks after their initial positive diagnosis. Interestingly, we have started testing the folks who tested positive back in April and May for antibodies, and we are finding that a large portion of them have antibodies. So we're hoping that over the next couple of months, that will show that they have some protection or immunity against coronavirus. Your second question about sports, absolutely not. There's just no way. I mean, we just found out, even if you use Major League Baseball, that 13 or 14 Marlins from Miami tested positive and then came to Philadelphia to Citizens Bank Park and exposed all of those players and everyone they came in contact with. We need to see an example of getting it right before we continue to unveil. I have 3 sons. They are driving me crazy. You know, they run track, they play basketball, they do swimming, tennis, gymnastics. No one's doing anything. The only thing I've found that's somewhat socially distant is swimming, and not swimming inside, but swimming outside, because your coach can be on a deck and the child can be in the water. But all these contact sports where, you know, kids are spitting, they're touching hands. My son, when he plays basketball, he does this to get the sweat out of his eyes 4 or 5 times, you know, and they're seeing the major league sports, and the kids want to play because they're like, oh, their training camp started and baseball started and basketball's playing in a bubble. We can do it. But there are already problems. There were like 70 NFL players that tested positive. You know, one of the players, even though they're in this bubble, they're demonstrating that they don't even have restraint, and they can't stay in that bubble because they're going out to go get something else to eat, even though something's being brought to them. And then for the baseball, they came from Georgia, which was already endemic when 1 in 4 person has coronavirus. They came from Miami, which is like the new epicenter down there after New York. And then they came to Philadelphia. And so that's just irresponsible. In fact, if they were following the recommendations from the governor that states, if you come from states like Florida or Georgia, Alabama, California, you're supposed to quarantine for 14 days before you come in contact with Philadelphians. Clearly, they didn't do that. Had they done it, however, we would have known, and they would never have been in contact with the Phillies or the people in the hotel or the people that delivered their food. And so my answer is no to the sports. And your previous question, we have not seen anyone sort of test positive twice in our group. I could talk to you more offline, but could they, if they didn't mount antibodies the first time, technically they could test positive twice because the antibodies are what protect you from developing the disease. Not everybody develops antibodies when they have coronavirus. So.
Thank you, Dr. Stanford. I appreciate you, and thank you, chairs. I appreciate you both.
Okay, I think next is Councilmember Gim, and then we'll have Councilmember, because I do think Councilmember Catherine Gilmore Richardson had already made a request, and then we'll have Councilmember Gauthier.
Thank you so much, Council Chair, and I really appreciate this hearing. I just want to send greetings and gratitude to my colleagues in the State House. Thank you for all your work and any efforts that you can do to distribute information and resources, more not so much information, but to ensure that resources actually make it out to large cities and communities across the state. I mean, part of when we talk about disparity and the way to counter it is to actually address disparity, and somehow there needs to be some calculation in our resources. You can't just simply divide it by X number of counties that exist in the state of Pennsylvania and expect things to be distributed, solely by need as to what is technically equal. And then I also wanted to extend gratitude to the pastor, and my question though is for Dr. Stanford. And again, I think your comments today just really underscore the importance and need for your voice and presence to be engaged in a lot of areas and issues. The 2 questions I have for you are, one, how you would have evaluated the city's engagement with the Black Doctors Consortium or consulting through the process, as we dealt with the coronavirus response. As you know, council, thanks to all of my colleagues, made a huge point of underscoring a relationship with the Black Doctors Consortium to inform us on policy, practice, outreach, and significant change in the way we're handling the city's response and the medical response. The questions I have are, since then, do you believe you have been at the table with key discussions? You have made a really good point that we have brought up with the administration before, which is that there needs to be a significant conversation at the table with all the major hospitals. We are the largest American city without a public hospital system. All of our treatment, therefore, primarily goes through the private hospital route. And your presence there is critically important to the need for otherwise privately held, to be clear, profit-driven entities to reflect on their responsibility in addressing racial disparities, to purposefully and at cost to divert resources out to other areas where there isn't enough, even when they are not their own patients. And I think you made the point about the fact that they need to open up so that testing is to everybody, and that they need to purposefully do this, and that they don't have to go through all the barriers. So that would be point one. And then point two, my colleague, Councilmember Thomas, alluded to this. How involved are you with the School District of Philadelphia's reopening plan? Have you been consulted? There's lots and lots of disagreement right now. School districts across the country are, closing and going virtual online. I will also say that as a mother, as a council member, as somebody who cares deeply about the public health of people, I also do believe actually that the opening of school is the largest, most proactive, affirmative public health outreach campaign, should not be left into the hands of the school district itself. The district's reopening is not an education plan. It is the first time that we are compelling 200,000 children to come in, be affirmatively tested. If they are tested positive, we have no plan for that. We really need to hear what that looks like. And so my curiosity is, you don't have to answer all of those issues, but how engaged and involved are you with the School District of Philadelphia's reopening plan? And what would you like to see your role as being going forward? You're a pediatric surgeon. Thank you so much, and I appreciate your work.
Thank you very much for those questions. So first, I am not at the table. I would like to be at the table, specifically as it relates to the city and how we are combating and trying to go towards racial equity in the face of COVID and beyond. So when I heard there was going to be a great announcement today, I reached out to Dr. Farley. He and I had a conversation yesterday, and I actually said, you should have invited me to talk about racial equity in Philadelphia as it relates to COVID. I mean, that's been my life for the last 4 months, and arguably my entire life, being born and raised in North Philadelphia and educated in the Philadelphia public school system, and then throughout the state of Pennsylvania at Hershey and University of Pittsburgh. However, he did comment that there were representatives on the task force that came up with the plan for racial equity. But my comment to him was that it's different when you're in a building versus when you are in the community. And I am fortunate that I straddle that, and I'm sort of both ways. I can be at the table, and I can also interact with folks in Kensington and West Philly and North Philadelphia, right? And I personally believe I would be an asset for that. None of us has a lot of time, but it's important that as we're going forward, that you can bring these up. And he and I discussed some of the things I mentioned today, and he did not disagree with it. But I think sometimes until someone puts it in front of you and says, because it's not intuitively, oh, well, we should ask Dr. Stanford, she's right here in the city. It's not intuitive. I mean, and some of that is our own implicit bias. I'm just being honest, that you don't think about it. Well, I already have these two people. They should be bringing forth the same information, but it's not, and quite frankly, just because everybody is Black doesn't mean we all have the same experience. And, we've seen some of the same things. And the stories I can bring from what you're seeing, and I could share with someone who has the epidemiologic background and has all these hot spots mapped out. When I tell you what I see with Ms. Johnson, then you can help, and we can collectively come up with a plan for those hard hit zip codes. So no, I haven't been invited. Yes, I would like to be at the table. Regarding the school district of Philadelphia, having been educated in the Philadelphia public school system and having 5th grade and 7th grade students, I would love to be a part of that. And also being a pediatric surgeon, I take care of kids, primarily. I think the input I would add would be helpful. Definitely a rollout system would be ideal. I haven't been contacted by the school district of Philadelphia, but I have been contacted by many of the charter schools. All of the charter schools have reached out to me asking about testing and how they can separate their classrooms and how, they could screen with pulse ox and temperature checks as kids come into school. So I have been getting calls, but not directly from, Dr. Height, and they may already have their committee, who knows. But would I be interested? Absolutely. I would be very interested in that.
Thank you so much, Chair. And yes, I just wanted to say very briefly to Dr. Stanford, I know you want us to put you out of work, but I hate to tell you, in order for us to do that, we may be signing you up for a few things, but only with the hope of seeing transformative change. Thank you very much.
Thank you, Councilmember Gim. Councilmember Gilmore, Richardson, and Gauthier, if you could ask your question very quickly, because I would like to get to Dr. Farley and get a chance to talk about the COVID interim racial equity plan that just came out yesterday.
Thank you so much, Chairman Green. I will defer my time to Councilmember Gauthier because she asked to be recognized first, and then I'll come right back. Thank you.
Thank you, Mr. Chair. Good morning, Dr. Stanford. I really just wanted to, thank you for all of your hard work in helping people in our communities to get through this pandemic. I also wanted to thank you for so clearly outlining the racial inequities present in the way that we continue to respond. I represent the 3rd District. 2 of the zip codes in my district, 19143 and 19139, were listed as having the most Black people and people of color hospitalized for COVID. And so, I have a vested interest in working with you on the recommendations that you outlined. And so following this hearing, I would love to talk about those recommendations and push for them as it relates to the institutions in my district, Penn and CHOP. So I'd be grateful if we could have that conversation. And thank you so much again for your powerful testimony.
Thanks.
Councilmember Gilmore Richardson, were you going to ask a question or come back later?
Yes. So thank you, Chairman Green. I just wanted to thank Dr. Stanford and Reverend Mitchell and the entire Black Doctors COVID-19 Consortium for standing up in operation in our city and our Commonwealth, and really our country owe you a huge debt of gratitude and appreciation. My question for you is related to children. You're a pediatric surgeon. I'm a mother of young people. I have a 3-year-old, a 5-year-old, and a 14-year-old. So my question is relative to being able to get little people tested. I was able to get my children tested for COVID-19, but it was a process, and we called CHOP. I actually called CHOP, and CHOP stated we needed a referral from our primary care physician. So I was able to call our primary care physician, and he provided the testing in office, but there was a load of procedures that we needed to follow. The lobby had to be clear before we came in, just making an appointment. It was very, very difficult. So I wanted to know, what is your specific recommendations for parents of little people as it relates to being able to get them tested for COVID-19? How can we help parents with little people?
Wow. That's an excellent question. Well, you can come to us. No, I'm kidding, but I'm not kidding. Myself, we also have pediatricians. I have family practice folks that work with us, nurses who are experienced 25, 30 years in. We've tested as young as 8 months and as old as 89 in our group. And so through our group of staff, lots of us are familiar with pediatric patients. You know, I empathize with you. For the kids, it's hard. And certainly when we are testing, there's always someone that can test the kids for us. I know at Einstein, the pediatric department did reach out to us and ask, can we help with testing their patients, which we certainly can do that. But it just goes to your point, as we hopefully are going to set up something where a hospital takes on a testing every day of the week. Certainly CHOP, who could test children and adults, would be a big push for that. And honestly, any ER that sees pediatric patients and can put in an IV should be able to do a nasal swab or an oral swab for coronavirus. And so, again, it just points to why the hospital involvement is critical. And I don't just mean you're here, come in, but knowing that, again, from 9 to midnight or whichever, someone can get tested and have something set aside for children.
Okay, well, thank you so much, Dr. Stanford, and my team and I will follow up with you relative to ensuring that children across our city can be tested for the coronavirus. Thank you so much for your work. Thank you, Chairman Green.
Thank you, Councilmember Gilmore Richardson. I want to thank this panel for your testimony, for the work that you're doing, the leadership you're doing both in the State House, the State Senate, and also locally with both Dr. Stanford as well as Reverend Marshall Mitchell. We're going to have our next panel speak now. Earlier, I talked about Einstein, which kind of follows up on Dr. Stanford's point about opening up testing, and I was informed that they are doing testing on weekends until 8 o'clock p.m., and no script and no ID is necessary, but they do need an appointment. Also, following up to what Senator Haywood talked about, as well as Councilmember Gautier, we will kind of put together some either some letter or some other type of correspondence. Hopefully we can work with Dr. Farley on that in reference to other hospitals to expand their testing, which is actually part of his COVID interim racial equity plan about including testing. So with that, I will stop my commentary, and Mr. Iannuzzi, if you could go on to the next panel.
Commissioner Thomas Farley, Commissioner David Jones, Fort Wayberg, and Dr. Alberto Eskenazi.
And due to the interest of time, if each speaker could go through their testimony, and then we'll come to comments and questions after that.
So, council member, would you like me to speak first?
Yes, yeah, absolutely. You are hot in the hot seat. but I love your background.
All right, thank you. Good morning, Chairpersons Bass and Green and members of the committee. I'm Dr. Thomas Farley, Health Commissioner for the City of Philadelphia. Thank you for allowing me to provide testimony regarding resolution number 200310 on racial disparities and the COVID-19 pandemic. Current data from Philadelphia shows marked disparities in the impact of the novel coronavirus pandemic by race and ethnicity. As of the past weekend, the Department of Public Health has recorded 846 deaths from COVID-19 in African Americans, 461 deaths in whites, 146 deaths in Hispanics, and 49 deaths in Asian Americans. Death rates per capita from COVID-19 for African Americans were 50% higher than those for whites. Hispanics had an overall mortality rate that is lower than that of whites, of white non-Hispanic residents. This was in part because they tend to be younger. Within every age group, Hispanics had higher death rates than non-Hispanic whites. This is a national pattern. In fact, racial disparities in COVID-19 mortality are greater in the nation as a whole than in Philadelphia. According to CDC data, African Americans in the U.S. have a COVID-19 mortality rate that is more than double that of Caucasians. In this regard, COVID-19 appears to be following a pattern of other health problems. African Americans have higher mortality rates than whites for a wide range of diseases and injuries, from heart disease to diabetes to homicides. These disparities are one result of structural racism in our society that reaches back across generations. The exact mechanisms by which this legacy affects COVID-19 specifically are not fully clear, but we can speculate about them. People of color are less able to work remotely and more likely to be frontline workers at risk of exposure to the virus. The legacy of redlining in our city means that Black and Latino city residents are more likely to live in crowded housing where they may be unable to safely quarantine if exposed to COVID-19 or to isolate if sick. And our Black and Latino city residents also have higher rates of chronic conditions like diabetes and heart disease that increase the severity of COVID-19 infection. Although this is a national problem, we have a responsibility to do whatever we can to address the issue locally. To that end, I've asked members of my department to develop a COVID-19 racial equity response plan with input from internal and external stakeholders. This plan was released yesterday. It recognizes that no single action will end these health disparities, so it includes work across 8 sectors. These sectors are, first, improving access to COVID-19 testing. We have worked with partners across the city to expand testing access with an intentional focus on Black and Latino neighborhoods. There's more to be done, but we have made significant progress. From mid-May to last week, the number of Philadelphia residents tested per day doubled from 1,500 to more than 3,000. Of the people tested so far, for whom we have information on race and ethnicity, 54% were African American, 27% were white, and 9% were Latino. Second is tracking racial and ethnic disparities. We are now posting data daily on the phila.gov/COVID website on testing, cases, hospitalizations, and deaths broken out by race, ethnicity, and age. Third is conducting community outreach. We heard from community partners that there was a need for clear, simple, graphic materials in multiple languages. We have worked to create and disseminate these materials through our community partners in food distribution baskets and via mass and social media. Next is preventing chronic health conditions. We have taken a policy, systems, and environmental approach to preventing chronic diseases like diabetes, heart disease, and chronic lung disease that increase the risk of mortality from COVID-19. This city council has played a central role in this effort by passing laws to help reduce the risk factors for these chronic conditions, including laws that prevent targeting of Black neighborhoods by the tobacco industry, that require sodium warning labels to help prevent hypertension and heart disease, and attacks distributors of sugary drinks. The next is protecting essential workers. We have created simple infographics on required protections for workers and disseminated them via food distribution boxes, community partners, and to businesses. Then is preventing community spread. We have started a mass media campaign about masking, like the one over my shoulder, and placed the ads in locations where they will reach minority neighborhoods and populations. We're also partnering with Mural Arts Project and local artists to put out information about masks, distancing, and hand washing, with a focus on Black and Latino neighborhoods. Then is preventing spread in congregate settings. People living in nursing homes, shelters, prisons, dormitories, and other settings in which people are housed close together are at high risk for infection. We've been working with these sites to provide technical assistance in infection control to ensure that they have personal protective equipment for staff and residents. And final is contact tracing. Our new COVID containment division is completing the recruitment of a diverse contact tracing team that represents the people that we will be serving. The people hired to staff this new division, 52% are Black, 28% are white, 6% are Latino, and 9% are Asian. Of the managers of this division, 43% are Black and 7% are Latino. Racial disparities of COVID-19 infection are representative of deep-seated problems, so they will not be eliminated easily or quickly. Nonetheless, we will take the steps in our plan to reduce them and continue to look for additional opportunities to solve this problem. Thanks for the opportunity to testify, and I'm happy to answer any of your questions.
Okay, we'll then go to David Jones, and then Court, and then Dr. Eskenazi.
Great. Good morning, chairpersons Green and Bass and members of the Committee on People with Disabilities and Special Needs and on the Public Health and Human Services. I am David T. Jones, Commissioner of the Department of Behavioral Health and Intellectual Disability Services. Thank you for this opportunity to testify in response to resolution number 200310. DBHIDS is responsible for oversight of a provider network that funds services for children, youth, adults, and families in Philadelphia with behavioral health challenges and or intellectual disabilities. Much of our work occurs through 3 of our 6 divisions that comprise DBHIDS, Intellectual Disability Services, which also includes our Birth to 3 Early Intervention Program, the Division of Behavioral Health, where we integrated the Offices of Addiction Services and Mental Health, and then Community Behavioral Health, which is a 501c3 behavioral health managed care organization that authorizes behavioral health services for individuals eligible for Medicaid. Today, I will speak to the impact of COVID-19 on individuals with intellectual disabilities and behavioral health challenges, highlight how DBHIDS has worked diligently to sustain Philadelphia's provider network, and emphasize the need for additional resources to assist our most vulnerable communities in Philadelphia combating COVID-19 pandemic. We engaged in daily conversations with some of our state partners that included the Office of Mental Health and Substance Abuse Services, the Department of Drug and Alcohol Programs, the Office of Developmental Programs, the Office of Child Development and Early Learning, to advocate for system-level policy changes to support providers with their continuity of care plans. Some of the significant adjustments that were made at the onset of COVID-19 pandemic that remain in place include our state partners relaxing the regulations and issuing guidance regarding telehealth, which greatly expands providers' ability to use this treatment modality and therefore has a potential to reach a greater number of people. We quickly implemented, and this I really want to underscore, an alternative payment arrangement that was approved by OMSAS to financially support agencies to remain operational and continue to pay their employees. We were among the first in the state to successfully implement this payment structure, and we did not want the inability for providers to pay staff to be a barrier for agencies continuing to operate, employ staff, and obviously continue to provide treatment and support. We also supported inpatient facilities and congregate care settings by providing personal protective equipment when we had it available. We continue to operate 24/7. According to the Centers for Disease Control, individuals seem to be at higher risk in terms of, that is, people with disabilities seem to be at higher risk of severe illness from COVID-19 if they have serious underlying chronic medical conditions like lung disease, heart disease, or weakened immune system. Adults with disabilities are 3 times more likely than adults without disability to experience heart disease, stroke, diabetes, or cancer, according to CDC. Some people with developmental or behavioral disorder may have difficulties accessing information, understanding or practicing preventative measures, and communicating some of the symptoms of illnesses that they may be experiencing. Just in terms of federal aid to date, DBHIDS has not received any federal CARES Act dollars. However, we've shared information with our providers and encouraged them to apply for available relief aid programs, including the most recent CARE Act Provider Relief Fund. We've also encouraged providers to track COVID-19 related expenses in the event that federal relief dollars make their way to them directly. Our preliminary data on telehealth demonstrates enhanced satisfaction with the service providers the services that individuals have received. Obviously, it has significantly decreased the challenge around showing up in terms of the no-show rate. We firmly believe telehealth should continue and may prove to be an effective strategy for engaging minority communities who may have been reluctant to access services because of stigma. We also continue to use positive impacts in telehealth and advocate for its expanded use. We must explore investments in technology resources for families who struggle with accessing technology and the reliable internet. Prior to COVID-19, DBHIDS had engaged in research to identify racial disparities among individuals participating in behavioral health services via Medicaid, and we partnered with the University of Pennsylvania's Center for Mental Health to gain an understanding to the extent to which disparities existed. Findings from the evaluation provided insights into the need for more efforts to keep African American members engaged, especially younger African American men. We found this population to be returning home frequently to inpatient hospitalizations and not gauging then in that next level of care, if you will, in terms of outpatient services for mental health and addictions. As a result, specific interventions were introduced to assist engagement, including text message reminders and greater linkages after an inpatient admission to outpatient. Additionally, we created the Engaging Males of Color initiative to reduce the stigma and raise awareness of behavioral health treatment for younger African American men. from 2014 to 2020, engaging males of color reached more than 6,000 African American and other males of color through various venues, including town halls and symposiums. We certainly take our responsibility to ensure the availability of culturally competent services to our diverse members very seriously. Within the DBH-IDS network, it is critical for our department to create and maintain strong partnerships with diverse community organizations through initiatives. But we continue to also partner with a number of grassroots community-based organizations that provide various services that are not Medicaid compensable. Some of those organizations, for example, like Grands as Parents, Mothers in Charge, Hebrew Immigrant Aid Society, and the African Cultural Alliance of North America, along with Southeast Asian Mutual Assistance Association Coalition, and more. We continue to recognize the significant role that they play. We look forward to continue our work with City Council and other stakeholders. I will actually end there and just reiterate the point that I made around one of the significant changes that we made in a more of a certainly proactive measure was instituting the alternative payment arrangement. And I'm happy to answer questions about that and any other questions that you all have. Thank you.
Thank you.
Good morning, Co-Chair Greens, Co-Chair Bass. My name is Court Wayberg. I'm the Executive Director of the Mayor's Commission on People with Disabilities. In this capacity, I supervise the Mayor's Office for People with Disabilities in Philadelphia, including our constituent services and Office of ADA Compliance. I did submit written testimony. In the interest of time, I'll underscore a few points. First, I want to thank you all for having this hearing today, especially a few days after the 30th anniversary of the Americans with Disabilities Act. While we certainly celebrate the achievements that the ADA has provided in terms of employment, access to government and public services, COVID certainly has given our community a step back. Want to underscore that 16.8% of Philadelphia has a disability. That's around 250,000 residents. Only Detroit and Cleveland have a larger population of any large city. Just to underscore some of the effects on the disability community that COVID has wrought for us. When COVID hit, many people with disabilities were in congregate care facilities, nursing homes, group homes, personal care homes, correctional facilities. And unfortunately, over half of people that have succumbed to COVID have an underlying health condition or a disability. Abrupt changes in routines have resulted in people with intellectual and developmental disabilities having increased behavior issues and issues with home care. We've heard heartbreaking stories from folks that are just afraid or unable to leave their homes since this all started as a result of their change of routine and just the difficulty in either obtaining PPE for themselves or for their home care workers. Relatedly, people who are enrolled in the school district or other schools have had to adjust to remote learning, which can be very difficult for people with disabilities, whether it's accessing the technology or whether being able to understand what teachers are working on, or just having reliable internet services. This created a huge challenge for those individuals. In addition, many employees who are on the front lines have underlying health conditions or disabilities and cannot work from home, which means that they have either had their hours curtailed or just been furloughed or lost their positions. Now, some of the actions our office has taken, first and foremost, I want to underscore that one of the primary asks we heard from the community when this all started was people having trouble accessing food. The city did a terrific job of setting up food sites for people throughout the city, but if you have an underlying health condition or disability, you might be unable or be afraid to just leave your homes to get food. So we did a lot of collaborating. When we started the hearing today, Councilwoman Bass talked about silos and collaboration. And I think that collaboration is huge. We've worked with many organizations and city and state agencies to not only disseminate information, but to also develop a food program. One of the people that was, integral in this is Thomas Earl from Liberty Resources, who you'll hear from later. Working with him and our Office of Children and Families and other nonprofits, we've been able to deliver food to thousands of city residents with disabilities and underlying health conditions. We've also, from day one, contacted residents via phone, email, by mail, in any format needed to tell them about new resources from the city, the state, even the federal government, so that people with disabilities can access vital services and programs during the pandemic. We've also been working with school district, the Mayor's Office of Education and Policy, to ensure that remote learning can get off to a better start this coming school year. We've also held educational town halls to hear from families and students directly on how the difficulties of remote learning have impacted them specifically. And hopefully when things improve in the future, we've been working with city departments to try to increase employment for people with disabilities going forward. And now lastly, I want to underscore some things that City Council has done and can continue to do. Really want to thank you for adding money back into the Housing Trust Fund to help programs such as the Adaptive Modification Program. It's one of the only programs in the city that provides accessible homes for people with disabilities, both who own their homes as well as who rent their homes, so tenants. We also support funding from the city as well as state and federal government for home and community-based services. The more people we can keep in their homes, not only does that increase their independence and integration into the community, but it keeps them safe and out of congregate care facilities. This is something we've in the community talked about for decades, but I feel that COVID has certainly underscored the vital role that home and community-based services can play in keeping people safe and healthy. So I will stop there and happy to take any questions. Thank you all for your continued support during these difficult times.
Thank you, Dr. Eskenazi.
Thank you very much, and good afternoon to everyone. Let me first of all thank and recognize Chairman Green and Chairwoman Bass. My name is Alberto Eskenazi, as you heard. I'm actually a Latino, and I am a chairman of the Department of Physical Medicine and Rehabilitation for the Einstein Healthcare Network. I also serve as Chief Medical Officer at Moss Rehab, and we greatly appreciate the opportunity to testify on this critical issue. Before I get started, I wanted to share that joining me today is Nurse Julie Hensler-Cullen, who's the Director of Education and Quality for Moss Rehab, who has been very active in these issues. We would like to extend our recognition as well to Councilwoman Shirley Parker, who represents Einstein Medical Center in Philadelphia. Julie and I are both aware of the responsiveness and the great support this administration and council have provided to Einstein over the years. We're also very pleased that we have received an award from the Philadelphia Department of Public Health to provide, as you said before, community COVID testing. And this testing began actually this week and is available Monday, Wednesdays, and Thursdays from 7 a.m. to 8 p.m. and on Saturdays from 9 a.m. to 5 p.m. And it is provided at no charge to residents, but we do require an appointment. You don't need a prescription either. So if you call 1-800-EINSTEIN and then press number 5, you will get access to making an appointment. To put this pandemic into perspective, while much media attention has been focused in New York and more recently in Florida and Texas, for very good reasons, I would note that the United States Department of Health and Human Services recently distributed CARES Act funds to address the high COVID impact on hospitals. And Einstein Philadelphia received the second highest amount in this round of funding. This reflects the number of COVID hospital admissions between January and to June 10th. If you combine the patient volumes at Einstein and add those to Temple, North Philadelphia had the highest number of hospital admissions for COVID-related in this country. With that as a backdrop, I would like to share with you a short few slides, although I have provided the full presentation for the record. Let me just do that and hopefully get you quickly and timely the information. So no doubt that disparities in COVID-19 care and rehabilitation have been evident and have had a significant effect. I don't need to tell you much about COVID itself, except that we had this present into our shores in early March, and we have been dealing with it since. There have been so far more than 16.5 million people confirmed across the world, and about 654,000 individuals have passed. In the U.S., 4.3 million people have been confirmed with COVID, and we have had nearly 150,000 individuals die. In the state of Pennsylvania, this is data from this morning, 112,995 individuals have been confirmed, and we have had the misfortune of losing 7,174 individuals. These are Einstein cases, and I just thought I'd share with you, although this data ends at the beginning of July, you can see that we have had nearly 3,000 patients cared for in the hospital. So as Dr. Stanford mentioned, it's important to address the needs of these patients in the community, but if they need hospitalization, places like Einstein, who provide really essential care, are critical. When you look at the population, we heard clearly that there is a difference based on age, and you can see that the large majority of patients who are female in pink and male in blue appear to be younger for female and older for male. When you look at the distribution by race and age in this nearly 3,000 patients, again, African Americans have been really the individuals who have suffered the most. This is followed by Hispanics, and so we heard about that. And then there are a group of individuals who we were unable to determine their race due to either being too ill or not having enough information. We did hear a lot about the disadvantage of having comorbidities, and we know that individuals who are Latino or African American have a higher incidence of diabetes and hypertension, and we heard that very eloquently presented by Dr. Stanford, that it is really not those comorbidities that are a problem, but access to health care. When you look at these cases, at least for Einstein, we were able to treat most of the patients in a non-ICU environment, but 521 of them ended up in the ICU, and 359 of them had to be treated with a ventilator. Now, I represent the Department of Rehabilitation, and as such, I wanted to share with you briefly what we have done in that regard. Moss Rehab decided to implement a COVID-positive unit. This is a unit that treated patients in the acute phase of COVID, and we did this for several reasons. One, because patients tend to have debility after being in the hospital with a disease that is really affects not only the lungs but many other systems, and increases the risks of stroke and limb amputation. It also clearly has impacted our workforce across the city and has strained otherwise available resources for post-acute care. There is also good historical data from Medicare and other sources that around 30% of patients who are hospitalized with severe diseases, including sepsis, will likely end up needing rehabilitation. So we have been very fortunate. We were able to create a separate unit to address this in an attempt to address the needs of patients who would not be able to go home safely, and that may ended up increasing excess morbidity and mortality and increase the number of readmissions to the emergency rooms, which were already pretty strained. Treating these patients in a relatively safe environment, both for patients and clinical staff, with adequate planning, training, and equipment was important. And so we approached this by developing a Center of Excellence in Rehabilitation, a unit for patients with COVID. Patients treated in an assigned rehabilitation unit with a team that is dedicated to their care. It assures staff safety by training and appropriate use of personal protective equipment. And all of the staff working in the unit are monitored for fever and symptoms every shift. All radiographic studies and any need for hemodialysis are done in the room to avoid exposure to others. We open a 12-bed Core Plus unit, Core for COVID positive and RE for rehabilitation. We opened that unit on April 7 to deal with patients who are in great need for rehabilitation. Within 4 days, we were full, and we had a rolling waiting list of about 10 patients coming from all hospitals around the city. We have admitted so far, the slide says 58, but in reality today, we had 60 patients who have been discharged, with 78% of them going home independently. 12 returned to acute care, and 10% of the patients had to go to a skilled nursing facility. Our very first patient was a young man who was able to go home nearly after a month and a half of being hospitalized to his pregnant wife, who was 8.5 months pregnant, and was able to receive their first child at home together. We know that the medical acuity of these patients is higher, but so far our outcomes have been excellent, and we have been able to provide good care for these patients in need. The core unit...
Dr. Eskenazi, thank you for this information. Yeah, unfortunately, I have a hard stop, and
okay.
I do want to get...
we were going to just... There was just one slide, and that was the recommendations, and I'm going to let Julie talk about those. Julie?
Yes. Thank you very much. As Dr. Eskenazi said, Moss Rehab and Einstein staff are really proud to serve your constituents and grateful to be included in this hearing. Mission of Moss Rehab is to improve the lives of persons with disabilities, and access to care and services to healthcare has always been a part of our accessibility plans. However, that has certainly been intensified with this COVID situation we're all living with. Certainly, I encourage us to continue to advocate for adequate and safe, reliable transportation for all persons with disabilities. And I just want to highlight, we've talked a little bit about the important practices, including social distancing. So as businesses, healthcare facilities, public spaces really work to implement social distancing, we as a group need to recognize that this has posed different barriers for persons with disabilities. The visual social markings that many of us have seen out and about, make it difficult, especially for persons who are blind, to continue to be safe. And many of these visuals and the masks and promotions that we see are in English. So we need to continue to ensure that they are available in all formats that are accessible. I think that the wearing of masks obviously are extremely important, but that also has created barriers for persons who are deaf and persons who have difficulties with speech. We touched a little bit, I know the commissioner, executive commissioner spoke about the difficulty with accessing food, etc. I've heard from many people with disabilities who previously relied on the grocery delivery programs that the backlogs caused by so many of us other people using those services has really caused, challenge. And the adage of Nothing about you without you. As we begin to implement some of the calls for action that many of you have articulated today, I encourage us, obviously, to continue to include persons with different types of disabilities as members of the teams as we develop these plans. Thank you very much.
Thank you. That was, for the stenographer, that was Julie Hensler-Cullen from Einstein. I know the time is getting short, so I just wanted to ask Dr. Farley very quickly, and I know Councilmember Catherine Gilmore-Richardson has a quick question. You heard from Dr. Stanford, you heard from Einstein about their expanding, and I know one of the points in your COVID intent to racial equity plan is to increase testing. So the concept of reaching out to the various hospitals that have in-house testing, is that something that we should be reaching out, and is that something that's already happening?
So the hospitals do, in general, provide testing sites. They do testing for their inpatients, but they, in general, provide testing sites for outpatients. There are sites that Penn does and Jefferson does in the community. Einstein is setting up one with funding we provided. However, I do think that Dr. Stanford raises some important points. We want those testing sites to be as accessible as possible. I was unaware until she raised it with me, the idea that there was a sign you need to have ID. That's definitely a barrier that shouldn't be there. There's a second question about their laboratory capacity. So what's developed in the past 2 to 3 weeks is this major problem that you're aware of unacceptably long turnaround times for test results at the national laboratories for the community testing sites. So we have asked the hospitals about, is there a way that they could handle those samples? What we've heard so far is that they have difficulty with the capacity of doing that. But I do think we need to continue to ask that, because if they could each take some, then at least some of the people would get a test result in a meaningful time period.
Okay, thank you. Councilmember Catherine Gilmore-Richardson, I'll give you the floor.
Thank you so much, Councilmember Green. Really quickly, I have a question for Dr. Farley, and I just wanted to thank you so much for sharing the data that you have provided on the city website. My office has been sharing that information each and every day. But I had a question. I wanted to circle back to something that Councilmember Gim brought up around the school district. So with the school district planning to reopen to in-person classroom learning in the fall as of right now, in the plan, the district explains that the decision to close or dismiss school rests solely with the Philadelphia Department of Health. Can you explain what specific criteria or conditions or what the breaking point would be in order for your office to require schools to close or to move to a more hybrid plan?
All right, so when we presented to the school board last week, we laid out criteria for closing a classroom, a grade within a school, an individual school, or the entire system. I won't go through all those details here in the interest of time, but for the entire system, we didn't lay out a specific threshold that said if you hit this, then we shut down the whole system. We did lay out specific factors we're going to look at. We're going to look at what the evidence is of spread within schools. We'll look at the community rates, whether those are going up or down, and we'll look and see if there appears to be a connection between spread in schools and community rates. Any one of those, if it's bad enough, may force us to shut down the entire system. Or if we have all three of those, then we'd be much more likely to shut down the whole system. We also will take into account what's happening around the country. If there are other school systems that are opening and they're finding outbreaks in schools, then that would make us have a quicker trigger. Or conversely, if there are other school systems that are open and they're not seeing outbreaks, then that might give us more confidence. I think it's still an open question what the school district will end up doing in the city, but we'll stay in close contact with them. And if we do feel that it's unsafe, we'll say that.
Okay, thank you, Dr. Farley. And just really quickly, I asked this question of the district in one of our meetings, but how will we be able to adequately contact trace once school starts again? And then the third question I have is relative to the expansion of testing. Dr. Stanford in the Black Doctors COVID-19 Consortium provides testing within communities partnering with faith-based organizations. What type of expansion of testing can the city work on to bring the testing to these most affected zip codes that are predominantly African American, that's outside of our health centers, the federally qualified health centers, and the other locations that we already have identified?
Okay, so as far as contact tracing, we are building a contact tracing system with staff. I'm going to talk about that more at the press conference, which is going to start up soon. And you'll hear that we're still not doing contact tracing for everybody. In part, that's because just the volume of cases, and partly it's because not everybody either answers the phone or wants to give us their contacts. But we are developing a system, and we will do as best as we can with that system. The second question was expanding testing. So we are have offered funding for organizations to provide testing to underserved communities. Dr. Stanford's organization was the first group funded by them. By that, we were pleased with that. There have been, I believe, 9 other organizations that have received funding by that. The Einstein announcement here today is one of the outgrowths of that, but there are other organizations as well. So our goal is to have 5,000 tests per day. We are now about 3,000. So we know we got a long way to go, and we want to expand particularly in underserved minority populations and also populations that have difficulty in getting access to a testing site for a wide range of reasons. So those are criteria we look at very specifically with the organizations that are requesting funding.
Okay.
Sure.
Okay. Councilmember Gilmore-Richardson.
Questions later. Thank you,
Okay.
Mr. Chair.
Thank you, Councilmember Gilmore-Richardson. Dr. Farley has some additional questions regarding contact tracing, but I'll wait till after the press conference. I want to thank you for being here. I know we asked some very hard questions about the work you're doing, but I also want to commend you. Last week, I was on a board meeting for National League of Cities, and Philadelphia was recognized as one of the top cities, if not the top city in the nation, where people have a higher propensity to wear the mask. And that's due to the work and effort you're doing, especially based on the information, even in this hearing where you're educating people about wearing their mask. So thank you for your service, and we'll continue to ask the hard questions, but also commend you for the work that you're doing. With that, can we, thank you. Mr. Iannuzzi, if you can call the next panel.
Thomas Earl, Bryant Green, John White Jr.
Good afternoon, Mr. Chairman and Councilwoman Bass. Thank you very much for this opportunity to testify about the COVID pandemic in Philadelphia. My focus will be pretty singular. I am the Executive Director of Liberty Resources, which is the Center for Independent Living that serves people with disabilities throughout Philadelphia. We are federally funded through Health and Human Services, the Administration on Community Living. And our mission-driven work focuses on transitioning people from institutional settings like nursing facilities, like Philadelphia Nursing Home, Neshaminy Manor, and others throughout the area. And we provide transition services so that people can move out of the nursing facilities to live independently in the community. Our work depends on a large workforce of community caregivers, often referred to as home caregivers or attendants. The majority of our employees are women of color, and the pay rate that our folks receive is very low compared to their equivalents in nursing facilities. And we have been very troubled by the data that has come out of the Department of Health, the Pennsylvania Department of Health in particular, on the infection rates and mortality rates in nursing facilities throughout Philadelphia and the Tri-County region. I provided a report that was authored by one of our policy specialists, Liam Doherty, who's also a member and a commissioner on the Mayor's Commission for People with Disabilities. And the statistics that we have received are startling. And they're especially startling since it's really the tip of the iceberg. We would be able to say pretty confidently that probably a third of the nursing facilities in Pennsylvania, including Philadelphia County, are not reporting data on their infection rates for residents and staff. And the data that we have been able to access through the Pennsylvania Department of Health's website is summarized in the report that I provided to you. And in the interest of time, I won't go through that page by page, but it's safe to say that the rate of infection and mortality in nursing facilities is through the roof. For example, in Montgomery County alone, 93% of the deaths from COVID have occurred in long-term care facilities like nursing homes, and less than 7% have occurred from people living in the community. Our mission has always been that people have a civil right, people with disabilities have a civil right to be integrated members of society and live in the community with the supports and services they need, and that includes home care. We can serve probably 2.5 to 3 people in a community setting for every one that lives in a nursing facility. It's economically cheaper, and social policy, it's very desired. Almost all seniors and people with disabilities prefer to live independently as long as possible in their own homes and apartments. And we're proud in Philadelphia that programs like the Housing Trust Fund, which was recently funded, restored funding for accessible, affordable housing, has been maintained and not reduced. We're also working on innovative approaches like the land bank, which needs a lot of improvement to get vacant properties out to low-income households with affordable, accessible housing for people, including people with disabilities. But I would just like to go on to table 4 of my report. On page 5, it gives a very clear comparison of the mortality rate percentages compared to the community. And in Philadelphia, the mortality rate is about 5.3. This is community deaths per infection, about 5.3%, while in the while people in nursing facilities are facing a 27% mortality rate. They have a 25% greater chance of dying from the virus in a nursing facility than they would if they lived in the community. Montgomery County, the mortality rate for residents living in nursing facilities is 25.1% compared to 1% in the community. Delaware County, 23.3% in nursing facilities compared to 1.9% in the community, and so on and so on. We've taken a number of measures to help people move out of nursing facilities. At Liberty Resources, we have experienced 7 deaths from COVID virus with the people we work with, people with disabilities that we move out of nursing facilities. 4 of those deaths have occurred by people who were literally waiting to move out of a nursing facility into the community and were not able to do so quick enough. So they were literally trapped in a nursing facility and passed away there. We hope that with Governor Wolf's leadership and the Department of Health and the Commonwealth and also the city, that we can make a stronger requirement for nursing facilities to report their infection rates and their death rates, not just for residents, but also for staff. Many of the nursing facilities are reporting infections of staff, but they're not reporting the death rate of staff. So that's an absent data set that we would like to see. The services that we've been working with the city's emergency services, the Mayor's Commission with people with disabilities, as Court referenced earlier, has been tremendous. And it's really like deploying an army. And one of the challenges has been getting healthy food to people with disabilities who are unable, because of their compromised immune systems, to go to food distribution sites and wait in long lines. So some folks with disabilities are literally stranded in their own homes, not able to get out and get the food they need, or they cannot afford to get the food they need. To date, we've moved over 53 tons of food in collaboration with the city and Cynthia Figueroa and the Share Food Distribution Program. These are contact-free door deliveries where a driver and a food runner go out to about 25 addresses a day and knock on the door and leave household groceries for a family of four that lasts about 4 to 5 days. This has been a tremendous help. We've approached 4,000 deliveries this week, and it's a huge need, and we need volunteers. Another thing that we're doing is emergency attendant care for people who receive home care. Keep in mind that the caregivers are on the front line. They're exposing themselves to COVID and sometimes caring for a senior or a person with disabilities who has tested positive for COVID-19. We have an emergency backup service that if the attendant cannot make it to the person's home for whatever reason, including COVID-19 infection, we can send out somebody on an emergency base, deploy someone 24/7 to get to that consumer's home and provide the needed services. For us, prevention is huge. If we can keep people in their homes instead of nursing facilities, congregate settings, hospital settings, the stronger the likelihood that they will survive the pandemic. Our emergency backup service is, the phone number is 267-765-1580. And I want to thank City Council for the opportunity to testify, and I implore everybody to look at our report that was written by Liam, that was provided to all of you, and it also lists the top 20 nursing facilities in the Philadelphia area with the highest rates of infection and mortality rates, and we can, as a city, do better. We have a great healthcare system with major hospitals, and as Dr. Stanford and others have indicated, we need to leverage that resource and use it in the community, especially for frontline workers who need immediate testing and support. Thank you very much.
Okay, I believe John White and Brian Green.
I guess I'll go ahead.
Jump right in.
Finally. Good afternoon. Good afternoon, Councilmember Green and Bass and members of the Committee on Public Health and Human Services. Thank you for the opportunity to discuss racial and ableist disparities that have been exacerbated by the current pandemic. My name is Brian Green. I'm the parent of a young woman that is visually impaired. And I'm the owner of Always Best Care Senior Services in Philadelphia and surrounding counties in the entire state of Delaware. My agency serves seniors and individuals with disabilities in the Philadelphia area. Thanks to the dedication of our caregivers, Always Best Care has been able to keep up with the most vulnerable Philadelphians safe in their homes during this time. In addition to owning my home care agency, I also serve as a board member for the Pennsylvania Home Care Association, a state trade association representing more than 700 organizations that bring medical care, personal care, and end-of-life care into thousands of people's homes every day across the Commonwealth in this great city. In the interest of time, I don't want to kind of be redundant in some of the points that have been made, but I do want to hit some points. At the Pennsylvania Home Care Association, we like to say there's no place like home. It is the desire of most individuals to age in place and receive care and supports in their homes. Pennsylvania has one of the fastest growing aging populations in the nation, and many of these individuals need assistance to remain ambulatory and active. Individuals who are frail and or disabled should not be relegated into institutions if they are otherwise able to remain in the community, especially at a time when COVID-19 has had devastating consequences on those living in congregate care settings. Under the Community Health Choices Waiver, which is a part of the medical assistance program here in Pennsylvania, individuals receive non-medical personal assistance services that help them maintain their independence at home. I wanted to speak to the underlying conditions in the minority population. Social determinations of health have left minority populations in urban areas at a disadvantage. Minority and low-income populations are more likely to be underinsured, and these create a barrier of care that precludes these populations from seeking consistent and regular health care in order to combat chronic disease. Conditions such as obesity, hypertension, and diabetes, among others, which are especially prevalent in Black and Brown communities, are complicating factors for individuals who may contract COVID-19. Increased challenges for individuals with disabilities. Living with a disability creates daily challenges and barriers. Because COVID-19 is a rapidly changing, uncharted situation, information has been disseminated at a rapid pace. At times, this can create a challenge for those who have vision, hearing, and cognitive disabilities. This puts vulnerable populations at risk as they may not have time or ability to comprehend rapidly changing guidance or safety measures. This is further compounded in minority and low-income populations, where access to things like internet may further exacerbate the inability to receive the most up-to-date news and resources. I want to speak to the disproportionate number of minorities serving as a part of the essential workforce. The direct care workforce in the home care industry is disproportionately, I can't even talk today, made up of minority women. In Pennsylvania, these individuals are doing incredible, important work, keeping our most vulnerable safe in their homes for an average pay of just $11.50 an hour. Given their essential work status, they are unable to work from home, and in many cases rely on public transportation in order to commute to their client's home. Since March, these caregivers have selfishly risked their own health as well as their family members' health to ensure that those they serve continue to receive necessary care. They are risking contracting COVID-19 has been exacerbated by the ongoing shortage of PPE. Home care agencies who employ these courageous frontline heroes have not been prioritized by Pennsylvania Department of Health for personal protective equipment. However, the Department of Health has prioritized consumer-directed direct care workers in long-term care facilities. It is wrong to not equally prioritize the safety of direct care workers employed by home-based care agencies, as these individuals play an essential role in keeping vulnerable populations out of congregate care settings and hospitals. As a business owner operating on the healthcare continuum, I, like all of my colleagues, braced for impact when PPE shortage became imminent. Since the start of this pandemic, we have not only seen shortages of PPE, but price gouging has become a prevalent practice in PPE sales. Ensuring the safety of my employees is paramount, and I am sure that my fellow home-based care providers across the Commonwealth and the country would echo that sentiment. We have creatively sourced PPE, and creatively is an understatement, and paid exorbitant prices to ensure adequate supplies are available for our caregivers. We should not have to wait with bated breath to see if the shipment of PPE placed actually arrives to our agency doorstep. Our direct care workers, especially those who are part of the Black and Brown communities where health disparities already existed, should be fairly recognized and prioritized for PPE accordingly. In conclusion, I'd just like to say thank you for your time and attention to these very important issues. Home-based care providers are a critical piece of the healthcare continuum, and as the direct care workers, nurses, and therapists who bring quality care to the home. Thank you again.
Thank you, Mr. Green. We actually have to go to the mayor's press conference, which is at 12:30. So we're going to take a break, and hopefully we'll be able to come back because there's another council hearing this afternoon. So we're going to take a break because I know they have to go over to cut off to the mayor's press conference. which are probably about to do that any moment. Okay, Lonnie, thank you for this reconvening of this council committee for people with special needs and disabilities and public health and human services. I want to thank my fellow members of council who are here for being able to stay with us this afternoon. I know the chair of the Public Health and Human Services Committee, Cindy Bass, is present, as well as council member Catherine Gilmore Richardson, Council Member Isaiah Thomas, Council Member Maria Kiona Sanchez, and Council Member Helen Gim. I want to thank Tom Earl for his earlier testimony, as well as Brian Green. If our clerk, Mr. Frank Iannuzzi, could read the next panel.
Judith Emmons, Brenda Shelton-Dustin, Joe Mancini, Asher Kemp.
And thank you all for your patience. If you could testify in that order.
Hi, can you hear and see me?
Yes.
Okay, great. Thank you. I'd like to start by saying Councilmember Green, Councilmember Bass, and other distinguished committee members, I thank you for this opportunity to address Resolution 200310 and for hosting this joint hearing to address the striking disparities of coronavirus infections and the impact they've had in Philadelphia communities. It's encouraging to see the thoughtful coronavirus racial equity interim plan that was released by the city just this week. I'm here representing my role as Director of Primary Care at Congreso de Latinos Unidos, where I oversee our federally qualified health center. In FY19, Congreso served over 15,000 individuals, most who reside in North Philadelphia, over which 60% recorded an annual family income of less than $10,000. 67% of these individuals identified as Latino, and 33% identified as Black, and 57% of our clients reported their primary language as Spanish. Our FQHC operates in a federally designated medically underserved area, which means there are not enough medical professionals in our community to meet the need. At our health center, we offer primary care services and a host of other supportive services to our patient panel, which consists of over 3,500 Philadelphia residents. And we also serve as one of the public coronavirus testing sites in the city of Philadelphia. It's clear that from the city's data and our own observations that racial disparities are disproportionately contributing to more severe negative health outcomes of coronavirus here in Philadelphia. We know that from recent data from the Philadelphia Department of Health that Blacks and Latinos make up over 70% of total coronavirus hospitalizations in our city, meaning these groups are disproportionately experiencing the most severe outcomes attributed to the infection. I can affirm from the work that I do that the disparities we are seeing are less about pre-existing conditions like diabetes or hypertension, and much more about the structural factors and social determinants of health that contribute to these risk factors. It is a common understanding in public health that the zip code and neighborhood conditions you live in have the most impact on your health outcomes. And actually in Philadelphia, the difference in life expectancy across zip codes is one of the starkest in the country. The patients served at the Congreso Health Center are often dependent on safety net social services, which have been compromised and continue to remain in jeopardy. Food insecurity in the first weeks of the pandemic was something that our medical providers saw multiple times per day. Telehealth visits for patients with chronic diabetes turned into conversations about where to acquire their next meal. This highlights just how unstable food security is within these communities, how close to the poverty line people are really living, and how another interruption could quickly put us back into that situation. The families we serve continue to struggle with increased behavioral health needs as a direct result of the pandemic, and the PHMC network of health centers has seen a 29% increase in behavioral health visits since the start of the pandemic. The Congreso Health Center serves a population of workers in which many do not have the privilege of staying safe at home. Many of them are working in essential industries such as labor and service delivery that keep the city going through the shutdown. Most of the workers in our community also do not have savings or financial security to fall back on. And many of these essential workers also have pre-existing conditions that put them at a higher risk for more severe outcomes. However, they still continue to work because they have no other choice. And sadly, some continue to work even if they're feeling sick, which can facilitate the transmission to others in the community. Additionally, the current delay on coronavirus testing results only further exacerbates the spread of coronavirus in vulnerable communities, and our medical providers do not have access to timely, accessible data that can help them make decisions for those who test positive and are at risk for more severe health outcomes. In April, the Congresso Health Center experienced an influx of new patients from a virus outbreak at a food processing facility, and that outbreak was worsened by the fact that the employees had mixed legal status. These employees shared with our medical providers that they were unable to stop working even as those around them became sick, that their employer did not allow for paid sick leave, PPE, or even opportunities for social distancing in the workplace. Beyond their increased occupational exposure, many were living in crowded housing arrangements that further exacerbated this situation. Fear of deportation or immigration-related violations is also preventing many undocumented Latinos and Latinos living in mixed legal status households from seeking testing and timely treatment for coronavirus. And under those circumstances, contact tracing among Latinos can even be further impeded by concerns about immigration consequences. Safety is also a chronic concern in our community, and as one of the 4 domestic violence service providers in Philadelphia, Congresso knows this all too well. During one telephone session with a domestic violence client, our advocate noticed that the client did not sound well. The advocate assessed the client's symptoms and determined that she met the criteria for possible coronavirus infection. However, the client disclosed that she had been sick for some time and was afraid to seek medical attention due to not having legal documents and medical coverage. A safety plan was created and the client was directed to medical care. However, she did not have the ability to safely quarantine within her house, and one of her children, unfortunately, also tested positive for coronavirus. Unfortunately, these are just 2 of many similar stories. Philadelphia's leadership and decision makers have a moral, economic, and public health responsibility to protect all people, regardless of race or socioeconomic status. In terms of coronavirus, we can do this by reducing barriers to testing and treatment, advocating to employers to ensure that people can work safely in quarantine, and by building trust and promoting cooperation with culturally competent contact tracing teams. But for the ongoing issues that continue to threaten the overall health and well-being of these communities, we must all commit ourselves to save Black and Brown lives through dismantling systemic racism and discrimination in order to address the social and structural determinants that are ultimately contributing to the disproportionately poor coronavirus outcomes in these communities. I'd like to end with a quote from Martin Luther King Jr., who said, "Whatever affects one directly affects all indirectly. I can never be what I ought to be until you are what you ought to be." This is the interrelated structure of reality. Thank you for your attention to this important issue and your commitment to the health of all Philadelphia residents.
Thank you for your patience, for being here and the work that Congresso does every day. I believe next will be Brenda Shelton-Dunstan.
Good afternoon, everyone. I'd like to thank you, Councilman Green, as well as Councilwoman Cindy Bass, for allowing me to testify. I am the Executive Director of the Black Women's Health Alliance, on improving health and health outcomes targeting African American women and women of glass that has highlighted the larger pandemic of health disparities and racial and systemic inequities. A crisis within a crisis for our community. The historical landscape of spiraling disparities at rates 2 to 3 times greater than the white community, and the resultant morbidity and mortality in the Black community was and is fertile ground for the virulence of COVID-19. Our organization was honored by City Council back in June 2011 and for our Creating a Legacy of Wellness, Mind, Body, and Spirit initiative in June 2nd. That day was Creating a Legacy of Wellness, Mind, Body, and Spirit Day for the City of Philadelphia. basically we were and still are uniting and mobilizing and working with diverse leaders to focus on improving our issues. We were able to roll out a program called Prime Time Sister Circle it's an evidence-based program focused on improving weight, which it did. 68% of the women lost weight. 40% of the women reduced blood pressure. Over 300 women have participated in that program. Unfortunately, we have not been able to maintain consistent funding of that project. Some of the recommendations that I'd like to give is there's an urgent need for development and implementation of policies that support these initiatives that focus on racism, conscious and unconscious, and the health and systemic inequities that exist within our healthcare systems and health at all levels. We want to be able to conduct this work in a transparent lens by honestly examining and developing comprehensive strategies with involvement of all stakeholders. Peeling back that onion, it may not feel comfortable, but it needs to be peeled back. We must be moved back to advance well-being in an inequitable world. There are some other programs occurring in other cities, such as Pittsburgh, where there has been established a Black-led collaborative looking through a racial equity lens, zeroing in on the racial disparities of education racism. We need to explore all options. There also is work, and I'm involved in this as well, occurring with the Pennsylvania Office of Health Equity Advisory Committee. I was pleased to hear Dr. Farley mention that some work has been occurring here in Philadelphia that I'd like to get involved with, and I will review that report that I understand was published today. Dr. Ala Sanford, the reason we need to be at the table for these conversations and have individuals at all levels involved in these conversations and meetings is because you're bringing different skill sets and information that may not be readily available. She zeroed in on hospital, the way it operates, and where the money is, how it might be opportunities. And she is absolutely right. There is opportunity there. The focus and purpose of those funds going to the hospitals is for community. So it's lifting up those conversations, digging in, and identifying where those intersections occur. And sometimes, we get involved in our silos. I'm not saying that it may not be that it is deliberate, but it could be an opportunity with all of us being at the table, coming at solutions, developing solutions, utilizing our different expertise and knowledge to address some of these issues. And I'm talking about including community residents, valuing, and I'm really serious about valuing their input. We may be involved in these committees. We are getting paid. We need their input, and we have to value that. This is something that I'm hearing a lot from community residents as far as their input is always requested for attending meetings, and they may get refreshments or they may get transportation. They may not, in the time of virtual, they may need assistance with the cable bill or whatever. But I'm saying valuing that input, because without our community residents who are going to the hospitals, going to the health centers, generating the revenue upon which the salaries are paid, it would not exist. The same, looking at that same lens as far as research, it's a research issue as well. How do we value that contribution that is being made by individuals who are considered as essential workers, individuals who may not be earning a living wage, but we're calling upon them for their time. Their time equals value as also talked about need for a comprehensive plan to focus on and address, going back to the racism, conscious and unconscious, and health and systemic inequities that exist within our healthcare system at all levels. Examine and improve those cultural competencies. Properly employ health providers and integrate comprehensive racism courses into curriculums for students involved in health professions programs. We got to go back and move forward. This racism issue is one that is embedded into our society, into our souls. It's an opportunity, and it is time for us to bring that education. COVID has placed health status on the radar in our community. Use it as an opportunity. It's an opportunity. We have their ear. Maybe not as much as we'd like to, but we have their ear. People are listening somewhere. But use that to increase awareness of steps that can be taken to reduce our vulnerability to COVID-19, health disparities, disparate conditions, and now those that will be in the upcoming fall, winter, and thereafter. Fund Black-led community-based organizations to conduct evidence-based interventions effective in reducing health disparities. The whole health and educational awareness campaign. This is fun. Partner with governmental funded contractors to assist with COVID-focused program out. There's a lot of funding occurring out there, and a lot of times it is not those organizations that are Black-led, community-based, owned and operated organizations who have an ear to the community. Let's lift it up. But it has to be valued. That knowledge and that relationship with the community has to be valued, and it is one that needs to be supported. Thank you.
Thank you for your testimony. We're going to wrap up with Asher Kemp and Joe Mancini. If you both can summarize your commentary. Also, I want to thank Ken Lawrence, the Vice Chair of the Montgomery County Commissioners. Due to some work, he was not able to get on to today's call. Also, we received written testimony from Charles Horton, who is now the Senior Director of Advocacy and Inclusion at Inglis House, Dr. Emma Chappelle from the Black Women's Leadership Council. Also, Judy Henderson, who was here through most of the day but was not able to testify, did also provide written testimony, as well as Dr. Ayo Marie Golden, President of the Delaware Valley Association of Black Psychologists, Dennis Cook, President and CEO of West Health, and Shane Janik, Executive Director of the ARC of Philadelphia. So we can go with Asher Kemp and then Joe Mancini, and then we'll wrap up the hearing. Asher, we cannot hear you. Hello? Asher, we can't hear you. So why don't we, Asher, we try to work with you in technology-wise. Let's go to Joe Mancini, and then we'll come back to Asher.
Councilman, can you hear me?
Yes.
All right, everyone. Thank you very much for your time today. My name is Joe Mancini, and I'm the Executive Director of Region 2 for Kencrest Services in Philadelphia. We're one of the largest providers of residential services for individuals with intellectual disabilities in the Philadelphia area, and our services span across 3 different states. Again, I want to thank you for allowing me the time. And although Sunday was the 30th anniversary of the ADA, and we have made significant strides in the push for equal rights for people with disabilities, individuals with disabilities are still often ignored when the topic of discrimination is discussed. Forget how, in the not so distant past, individuals with intellectual and developmental disabilities had been locked away, hidden from the general public and institutions because our cities were not equipped or did not want to address their needs. To this day, we are still struggling to create appropriate housing to move individuals from institutional settings. This pandemic is creating excuses for the general public to begin to hide those we support back in their homes, and because of the challenges accessing the community during this pandemic creates. I know we're short on time, and we have written testimony here, so I just really want to skip down to the part that discusses our need for support with direct support professionals. Residential programs like ours operate on a limited budget due to the rates set, and we often lean on other programs within our organization to offset the cost of operating our residential program. This pandemic has shut down day programs, early intervention programs, limited our employment and supported living programs, all of which we use to assist our residential program. We need support in educating legislators on the need for rate increases to hire additional competent staff that support our people in the community. Smaller residential programs will close without this support, and I believe that was mentioned earlier, some of the support that's being received, but we need more. And this will not only be heartbreaking for those that have established comfortable lives with these programs, but will also create additional stress on those that have to support the needs of the programs supporting the individuals moving. Direct support professionals are grossly underpaid. Sorry, I lost my place. Direct support professionals are grossly underpaid, many of whom are women, immigrants, and people of color that are not earning a living wage due to these rates. Quality DSPs are leaving these programs to find safer, less stressful, and higher paying jobs. A recent study by a large consortium of private service providers found that residents of group homes and similar facilities in New York City and surrounding areas were 5.34 times more likely than the general population to develop COVID and 4.86 times more likely to die from it. The Pennsylvania Department of Human Services reports that as of June 2nd, there were 801 confirmed cases and 113 deaths among people with intellectual disabilities and autism. Those we served estimated at 4.5 times greater rate to die from this disease, and we are creating work situations that drive away quality people that support them. We have a break-even household income they need of $90,000 per family of 4, and that's just not something we're allowing with these rates. With a competitive wage, we could keep these quality staff in place while they work. While the work of these dedicated direct support professionals has always been challenging, this pandemic has made this work life-threatening. We have lost amazing staff to this disease, and they literally have put their lives on the line so others can have a semblance of an everyday life. They need a rate that matches their dedication and sacrifice and allows these staff to continue to support people with disabilities and accessing their rights to full community engagement. Thank you for your time, everyone.
Thank you, Joe. We'll try Asher Kemp once again. If we can't hear from him, I want to thank him for his testimony. We'll have it included as part of the record, the great work that his organization does in providing information and resources and services on culturally competent providers in the behavioral health space. Mr. Kemp, can you hear us? Okay, you can hear me, but we can't hear you. So thank you for your patience. I really do appreciate you being here and all the great work that your organization has done. Too often when we're talking about these issues, we talk about one aspect of health, but not the behavioral health aspect of this, and your organization provides great work. I want to thank all of my colleagues who participated in this hearing. I know it's been a long hearing. Thank you for your patience. I also want to really thank my staff, Frank Guynuzzi, for helping to put together this hearing, as well as all the technical staff from the Chief Clerk, Mike Decker, as well as Lonnie and Modesto and all the technical staff and City Council. I know it's been challenging, but thank you for your work for this great hearing. Also want to thank my colleague, Councilmember Dom, for his indulgence as we're about to start his hearing. And I recess this hearing to the call of the chairs. And that will be myself and Councilmember Cindy Bass.